I think when you're on the fertility journey, every kind of practical step you do feels like a step closer, and it's a positive thing. I'm just having a checkup. Anyway, I woke up, I think, a good 2-3 hours later in a ward at St. Thomas's, beautiful view looking over the Houses of Parliament with the sun setting. A little bit confused, but didn't even know where I was. I'd just gone in, to have a checkup. Turns out that I had what they were looking for, which is something called Ashland Syndrome, which means that half my uterus was full of scars. So the uterus, normally the lining, which is what happens every month is, it builds up, it sheds, we bleed. Now, if you have scarring on the uterus, then there's basically a layer of scar lying on top of the endometrium, which means that even if it were to build up, it's not shedding, which is why it had these super light periods.
That's a clip from our guest Emily, aka the Egg and Sperm Race on Insta. She's in conversation with our guest host Katy Linderman. Katy is Uber Barons Club online, and I'd asked Katy to chat with Emily because they've both had experiences of lining issues, and I thought it would be a really good way to share it with you and to talk more about Ashermans syndrome. You're also going to hear in this episode a conversation with Adrian Lower, who is a specialist in dealing with Ashermans. It's such an interesting episode, so get yourself comfortable. Hi, I'm Natalie, a wannabe yogi and recent rock painter, and I created the Fertility Podcast as an A to Z of the issues that might affect you whilst you're trying to conceive. We've got expert interviews as well as men and women sharing their struggles to hopefully help you feel less alone. I'm also a freedom fertility specialist working with you to support you better, basically with your mental health, because I want you to feel more emotionally in control.
And I'm Kate, and I'm an independent fertility nurse consultant and founder of my practice, Your Fertility Journey. I'm really passionate about natural fertility and particularly PCOS, and I love empowering women to take ownership of their fertility journey. I'm also a veg gardening geek and, embarrassingly, a recent road bike convert, and I think that's called my midlife crisis.
What's embarrassing about it? Don't you look good in lycra?
I couldn't bear the lycra shorts, it had to be lycra leggings.
And the pair of us are at some point going to do a sponsored bike ride, so watch this space.
You and I are members of, I always talk about us being a club that no one wants to join, but I know that you and I are members of a very particular club, the Thin Lining and Misbehaving Lining Club. And that's something that lots of times people don't talk about. We hear so much about eggs and sperm, but womb lining is something that we don't hear that much about, and especially problems with womb lining are not as common as problems with eggs and problems with sperm. So I'm really, really excited to have you here because I think it's so important that we talk about this.
Thanks, Katy. I think we called it the Thin Lining Brigade at one point.
Yeah, like it.
So my husband and I started trying for a baby about 5 years ago, probably now. We were 35 at the time, so I was kind of already aware that maybe, there'd be fertility issues, but didn't expect the years to come. After about 6 months of trying, we actually had some monitored cycles. I was put on Clomid for no apparent reason, and then the doctor we were seeing at the time said, why don't you just try an IUI cycle? And lo and behold, we got pregnant, super excited. I felt fine, everything was great. And then when we went for a private scan, I think it almost 11 weeks, I had a miscarriage, which means that I hadn't actually miscarried, but the fetus had stopped developing a week or so before, which obviously was, traumatic at the time. I just remember screaming on Holly Street and just thinking I need to get rid of this, ASAP. And even the thought of just having something that wasn't alive in you is traumatic. So I just walked over from Holly Street to UCL, to the early pregnancy unit there, and said, I've had a miscarriage. And they were like, have you been bleeding? I was like, no, but you need to see me now, and then sat there for hours, got seen. I remember a lovely doctor who was actually hugely empathetic, I remember at the time. And I was sort of, advised to have an ERPC. So it's basically a DNC. So it's basically scraping the uterus when they go in, usually under ultrasound, and they remove the fetus or the embryo. So they just go in and scrape. And this is important, obviously, for the lining bit. Had my ERPC, thought everything was fine, had a period within 6 weeks, thought fine. But then I sort of knew that my body didn't feel right. So I went back to the same doctor to just have an ultrasound to see if I was still ovulating. This is maybe 2 months later, and turns out that I had a large piece of the fetus still in my body, so remains, as it's callously called. So then I literally marched back into the same EPU, crying my eyes out and probably screaming, and said, you need to remove this. And they were like, have you had a bleed? I was like, yes. They were like, well, then you have to go home. I was like, no. And then I think I saw a doctor, and then they were like, I need to get my colleague. Never a good thing when the doctor needs to get a second opinion. And then they were like, I think you need to have another ERPC. So another DNC. I think there was like very, very traumatic 10 days, because they wanted to do it with a senior consultant to remove it, because, you know, at the time that it was eventually removed, I would have been 20 weeks, I think. So there was a long period. And to be honest, throughout my fertility journey, that was probably the most traumatic time of not knowing when they were going to do the second operation. And I would literally call the EPU at UCL daily, 3 times a day, and just cry.
I bizarrely had a very similar thing, in that I also had retained products, as they call
it. That's it.
So I didn't have a bleed, but it was that I was taking pregnancy tests to see if my levels were falling, and I was still getting positive tests like 4 weeks later, and my doctor was like, okay. And the thing was that actually on the ultrasound there wasn't anything, but my HCG was still through the roof. So then I had 2 weeks where it was clear that I was still basically pregnant but not pregnant. So I had 2 weeks where I was like, okay, well, let's see how your HCG comes down. If it doesn't come down, we're going in again. So I had a similar thing, and it was just awful, because I was, my body was still pregnant. I still had these enormous pregnant boobs and, everything. But I knew I'd had the baby removed 5 weeks ago.
Yes, completely similar.
It was awful. So I can completely relate.
And I think that with the miscarriage, I guess that is a key that your body still thinks you're pregnant. So when the first time I had it, again, I had, just like you, the huge pregnant boobs, and sort of felt I didn't have any nausea or anything, so I didn't have any other symptoms, but it was just the boobs and the tummy still felt pregnant. But at this point, when I had my second ERPC, I didn't feel pregnant. It was just sort of knowing that there was tissue still there. So eventually, just before Christmas, I had a second ERPC, and then I thought, it was fine. And I remember asking questions at the time, because the consultant said in passing, she was like, there might be some scarring. And I was like, scarring? I was like, what do you mean? She's like, well, and then I came back 3 weeks later and had an ultrasound. And I remember asking, I was like, what about, is there any scarring? And she's like, well, I wouldn't be able to see that here anyway. Anyway, it was Christmas, and I thought, we were like, fine, started trying for a baby again, didn't get pregnant. And then we had, through our GP, got referred on the NHS for, further fertility investigation. And then we, just by chance, the doctor we saw, doctor our age, quite a young female doctor, said, well, if you've had, 2 ERPCs, what are your periods like? And I was like, well, I've never had particularly heavy periods ever. But I think my periods are pretty light now. So she's like, she said, why don't we just book you in for a hysteroscopy, just to check, just to see what your uterus looks like, what your lining looks like.
And for anyone at home, again, you and I know these very well. What is a hysteroscopy?
Hysteroscopy is a procedure where they put you to sleep, and then they go into your uterus via your vagina with a tiny camera, just to look around the uterus to see what the lining looks like, to see what the environment looks like. Basically, it's what they try to look at, things that you can't see on an ultrasound.
Yeah, so for anyone, basically an ERPC, as you said, is done blind. So essentially they have ultrasound on your tummy, and they go in and they scrape and suck out the contents, and that's surgical management of miscarriage is done. And hysteroscopy, as you say, it's how they go in with a camera.
This was a good 7 months probably after the first ERPC, so the first surgical procedure. And I remember actually kind of it was a sunny day, and I remember walking into hospital not thinking, I was like, this, just having a checkup. It also, everything, I think when you're on the fertility journey, every kind of practical step you do feels like a step closer, and it's a positive thing. I'm just having a checkup. Anyway, I woke up, I think, a good 2-3 hours later in a ward at St. Thomas's, beautiful view looking over the houses apartment with the sun setting. A little bit confused because I didn't even know where I was. I'd just gone in, to have a checkup. Turns out that I had what they were looking for, which is something called Ashland Syndrome, which means that my uterus, half my uterus was full of scars. So the uterus, normally the lining, which is what happens every month is, it builds up, it sheds, we bleed. Now, if you have scarring in the uterus, then there's basically a layer of scar lying on top of the endometrium, which means that even if it were to build up, it's not shedding, which is why it had these super light periods, basically just a couple of brown. Might be a bit graphic.
We're talking about lining, and again, this is the point, right? The bleeding is really important.
I mean, fundamental.
What kind of blood is it? What colour blood is it? And how long does it go for? Is it clumpy or gunky? Like, we're gonna have to get over our squeamishness about this, because this is really, really important.
It is really, really important, because I hadn't even realised, that I virtually had no periods, and I think it was because I thought maybe my body's getting back, into sync after the miscarriage, etc. So half my uterus was scarred shut, which means I had lots of, so obviously when you cut your finger, your skin will heal and it will scar. So normally that doesn't happen in the uterus. The uterus rebuilds and the endometrium rebuilds. But in some cases, if it's scarred over, it becomes impossible for, an embryo to attach to the lining, to the endometrium wall. And then secondly, even if it did, the uterus wouldn't be expanding in the same way because it's kind of blocked. So it could be dangerous. I mean, it's unusual that you get pregnant if you have a scarring in your uterus, so if you have Ashermans, but B, also if you have got pregnant, it could be dangerous and you would probably likely miscarry at some point. But I didn't know any of this, so I just wake up at St Thomas's, this beautiful view, sun setting over the Houses of Parliament, in excruciating pain. I do remember my husband saying something like, "You punctured her," or something, and I was like, kind of just waking up in this day. So it turned out that I had scarring of the uterus, and what they did then was they gone in with the camera, and while they had the camera in there, they tried to remove the scarring. Now, there's lots of different schools on it, how you should be removing it. And I think in my case, it was burnt. They were burning the scarring. Again, different schools of thoughts. And, I've done a lot of research. It's kind of just burning it off, basically. Yeah. But what they accidentally did then was burn a hole through my uterus. So they had to go in through my stomach and fix and actually that was the pain, because I got gas in my shoulder, basically. So I was like in this.
You've gone in for a hysteroscopy, but ended up with a full laparoscopy. And
I consider myself a fairly research person. I literally just wake up with this shock of A, having this condition, B, not knowing what it is, and C, also having a punctured uterus and various holes in my tummy.
You've basically gone in with a lightsaber, waved it around.
Yes, correct. Yes, that's good analogy. Obviously, there was a little bit of a shock. I went home, recovered from surgery, all those things, and then started researching Ashermans, because the thing is, I hadn't even really heard about it. And then I had a complete shock, complete fright. And I was like, first of all, and actually when I woke up, they said you might still have a little bit of scarring in your uterus because we had to stop the procedure. So, and then started reading them, and I was like, well, if I've got 10 to 15%, as they said, then, possibly this can, be a problem going forward. So I ended up actually having a second hysteroscopy with what they called in the Ashermans world an A-lister. So there are certain surgeons in the UK and globally who are very well known for treating Ashermans patients. So I was lucky, and I was actually covered on my insurance for it. I did have a second hysteroscopy with an A-lister.
I was on the Ashermans group, so I know who the Premier League are.
Exactly. So, but it is important. It's just because it needs, somebody who has a lot of experience of removing it, somebody who knows how to treat. There are more surgeons in the country now who can treat them, and there's a list, but it's really, and there are quite a few of them on the NHS as well. And I think it's
very delicate surgery. And as you
know,
so this is again, I had two, and this is also interesting because again, it's if you are having them done privately, if you have medical insurance, although medical insurance doesn't cover fertility, they do cover, a lot of them do cover miscarriages, and they do cover gynae surgeries, and my hysteroscopies, because they were gynae to do with my periods and miscarriages, were covered. Worth knowing.
And I wish I'd had, for example, my second ERPC, I could have, or even the first one I could have had, again, because I was lucky to have health insurance through my work. I could have had them done, and I would have had them done quicker. So I wouldn't have had this, the most traumatic agony of 2 weeks of waiting for an appointment. If you do have health insurance, privately or through your work privately, then then it is definitely something worth looking into, obviously during COVID times now. So that was it. And then I just started researching, had my second hysteroscopy a few months later, because what they do is they also put you on hormone replacement therapy. So they put you on high doses of estrogen to try and get your lining working again, essentially, to get your uterus back in the...
Going to the gym, the way it's described, that every month when you're having the hormone replacement therapy, it's kind of like training your lining to learn how to do its thing.
Exactly. So you did that for 6 to 8 weeks, and then you kind of have an onset bleed to see how that's working. So I had my second hysteroscopy, and I didn't actually have much scarring left, which was good. So it looked like the scarring had been removed, which was great news. Both on the NHS and then privately, we were told that IVF is your best option here. And the reason for that being is that with the drugs, you can build up the lining a lot better than naturally, because looking at my periods, even post removing the scars, we're now almost 3-4 years down the line, I don't have the periods I had before. So I had also been tracking for years, our periods on a period app, just because I like the data, I guess. And if I compare to the day, to my periods pre, my periods post, it's kind of nothing. And I know my husband says, I can't wait for the day when we stop talking about your periods, because I will be elated the month I have like 1 day of red blood, and it's really like I'd be shouting from the lips.
Getting, and again, I can say it's so bizarre, and I think anybody in infertility world knows the thing of you're in this half state of half the time you're desperately, it's weird, you're supposed to be desperately not wanting to get your period, but actually when you've got lining issues, and I never had Ashermans, but I had very strong thin lining issues, so I was treated as if I was an Ashermans patient. You are desperate to see red bleeding, and you are on permanent knicker watch, and whereas when you're pregnant you're on knicker watch to try and hope not to see bleeding. When you're having treatment for thin lining or Asherman's type treatment, you are just desperately hoping to see red bleeding.
I haven't used a tampon since I've had Asherman's, so like my periods are completely different, and again I'm literally just like celebrating if I have like full day of red blood. That is important because it basically changed our fertility journeys. From then, getting pregnant actually relatively quickly in hindsight, it felt like an age at the time. Then they were like, well, IVF is probably your best bet. So we moved on to IVF quite quickly and actually had 3 not very successful rounds. We were extremely fortunate to get 3 rounds actually on the NHS, but they didn't work out, and we didn't have very much. And it wasn't maybe as tailored as I needed it to be, for the Ashermans. And then we moved on to do IVF privately, and because of, again, the years have gone by this time, and I'm older, so obviously the egg quality then plays a difference as well. So we were advised to have PGS testing, and we're lucky to kind of get 2 normal ones in the first round. And then I actually had the summer off, which was great. And I think, with infertility, I think having times off when you're not thinking about what you're eating, the drugs you're taking, etc. By this point, it hadn't just been like 4 IVF cycles, it'd also been the hormone replacement therapy. Basically, I've been on estrogen for years, like I don't know.
It doesn't matter where you are, your whole life is taken over by the one thing that isn't happening, and so you're
absolutely. So it's so having that break, and then we tried frozen embryo transfers and trying to build up the lining, but the truth is my lining just never got particularly thick, and I did have triple lining. I have had so many cancel cycles, frozen embryo, there's you kind of stop. It's kind of devastating. You have, at the time we had these 2 embryos in the freezer, and then you sort of can't use them, but eventually my doctor was like, we're just going to have to try, So we did, on a fairly decent lining.
When we say decent, because this is something, again, you and I know the shorthand of this, and we'll use all the lingo. We talk about, you mentioned triple lining. We talk about thickness, and we talk about appearance and triple lining. They're both important. What does good lining mean?
So triple lining means it's got 3 layers. A good lining is a nice, juicy lining. So anyone who's had a scan of the lining, it should be, looks white, but it's like this nice, juicy, thick lining. They measure the thickest part of the lining. They say that for an IVF cycle, really, ideally, you shouldn't have anything under 7 or 8 millimeters, because your chances are just so much smaller. The time I did get pregnant, because it was an IUI, I know that my lining was 11 millimeters. That was kind of my natural standard, I guess. A lot of people are, and you'll know this better than me, Katie, but a lot of people have kind of, 13, 14 millimeters, which I dream of,
It's this weird thing of numbers, like everything is this game of numbers, and you hear about, lots of people about numbers of eggs, but you become really obsessed with who knew that a millimeter could be so important.
I mean, absolutely. And that's what they kind of say, they don't really like to do transfers under kind of 7, 8 millimeters. Now, there are people who've got pregnant on 5 millimeter linings, but the chances are smaller.
Research says, I think, that like 7 millimeters, like bare minimum, and most centers won't do it. Preferably 8, preferably 9. And again, I think the important thing is that when they're measuring this, they're measuring it at essentially at the time you would trigger. So it's at the bit where you're still on the estrogen, because what happens is after you start taking progesterone, so whether that's after you've had egg collection or when you start progesterone for a frozen transfer, your lining changes. So you're measuring this before because the lining acts differently under estrogen when it's getting nice and thick and it's thickening and thickening. And then after the progesterone, that's when it changes and it's essentially turning on. And that's when the whole receptivity thing kicks in to go, right. And then the lining changes appearance. So whenever we're talking about this, we're talking about looking at the lining before progesterone, because after progesterone, the thickness kind of doesn't matter and it will look different. So I think that's
exactly. So that triple, the nice triple lining you should see, it condenses with progesterone, so it just looks like a blob, basically. There isn't a lot of research. There's quite a lot of guesswork. You start taking your progesterone and then you transfer 5 days later. Now, because I've had all these issues, and because we've had 10 IVF cycles, and they haven't, no embryo, even PGS normal embryos. So they say that if you have a healthy uterus and a healthy endometrium, you should have a 75 to 80% chance of it working with a PGS normal embryo. Again, these aren't my figures, but that's kind of the figures out there. If you don't, if your uterus and your endometrium isn't receptive at the right time, then again, you might have issues. And that's the thing, there's just not enough of research.
I can completely relate to what you've said about, I felt like I wasn't getting off the starting block. Other people I could see were having, it's this really messed up thing where you see lots of other people who are having loads of failed cycles, and I actually got jealous of people who could say BFN, 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 because I thought, well, at least you're getting off the starting block. I can't even get to a transfer, and we had embryos in the freezer and I couldn't get there. I had a very adversarial relationship with my body because I just didn't trust it, and my periods were really upsetting and that emotionally, and so I just thought of my body as this place where embryos went to die, and it was very difficult.
Yeah, completely. I mean, I can completely relate to that, and I think it's just that the thought my body's just not working, and so I think I had, in a sense, sort of two sides. At one point, I had a lot of anger, I think, as well, and a lot of anger because I felt like somebody else had destroyed my uterus.
Yeah.
So I think that part, those emotions were important to work through as well. I mean, I don't feel angry now, and people say to me, "Why wouldn't you sue the doctor, etc." And for me, there's no gain in doing that. Nobody could tell me why my uterus was scarred, why I got Ashermans and not, the woman next to me who also had an ERPC, So again, there's not enough research, there's not enough science in it. So I think that, especially in, not getting off the starting block, but also I think I've had 10 embryos transferred over the years. So we've had 8 fresh cycles, some of them were freeze-alls. But then we've also had 2 embryo transfers, frozen embryo transfers, and then a lot of starting and stopping. You feel like a failure. You're like, the one thing that you were kind of put on this planet to do, you can't do. So I think that emotionally that's really hard, but we just go through the motions and you think, is it my eggs? Is it, the embryos? But then we had PGS normal embryos. So we didn't have loads, but we had quite a few. And, I managed to produce them each cycle, at least last year, not this year. But so you sort of go through the motions, but then you just keep moving your goalposts, I think. So eventually last summer we gave up, in a sense, on my body. We had just had another failed embryo transfer with PGS normal embryo and decided to pursue surrogacy. And that, in a sense, was a relief because it's not my body having to do it anymore, and it's not me after all these years. And we are luckily now pregnant via surrogacy, which is amazing. And it just made me see, you know, go through actually our surrogates frozen embryos transfer cycles. 2 of them were cancelled as well, and the clinic kept cancelling them because a lining wasn't 9 or 10 millimeters, and it didn't look absolutely perfect. And I was just saying I would have, you know, done anything to have this 9 or 10 millimeter lining. So I think it just kind of showed really what we were up against. And I think when you're amidst it, when you're on the kind of the treadmill, you're so desperate for it to want to work. But I'm so happy now that we actually moved on, and we are getting, you know, hopefully at the end of the summer, our baby. It's just not the way we ever thought it would be. It's a huge relief, actually. I just feel calmer in a sense, because I'm not on drugs anymore as well, you know. I'm over it.
Well, thank you so much to our guest host, Katy Linderman, whose details will be in the show notes. You can find out all about what she's doing with her Uber Barons Club there. And Emily, what a journey. And I'd asked Emily for an update because that chat was recorded a little while back. You may well have heard Emily chatting with Emma and Gabby on Big Fat Negative, another brilliant fertility podcast. But Emily's given me the latest because the pair of them chose to go down the surrogacy route, choosing to have a Ukrainian surrogate, which isn't an easy path, and they shipped their remaining embryo in a thermos flask with a stranger on a plane from London to Kiev last year, and found out on Christmas Day that they were expecting their baby. And they thought things were going smoothly. They had a 13-week scan in February, and you know what I'm going to say, because obviously COVID-19 happened and lockdown hit. So Ukraine closed its borders and airports in early March, making it just impossible to enter the country. And Emily spent a lot of lockdown writing letters to her MP, the foreign minister, the shadow foreign minister, and eventually she did get a response from the Foreign Office to say that they would work with the Ukraine Ministry of Foreign Affairs to support their case. So the Ukraine has recently opened its borders, and there are now a few commercial flights weekly to Kiev. So things are looking brighter. However, the UK is on the Ukrainian COVID red list. So that means a self-quarantine of 14 days is mandatory when you get there. You have to use an app which can only be downloaded on a Ukrainian number. And you've got to have the app when you cross the border. So there's now this option for them to reduce the quarantine period if they can produce a negative COVID test, which has to be taken in the Ukraine within the first 24 hours of landing, which basically means Emily and her husband are currently trying to navigate how they will get to Ukraine, get hold of Ukrainian SIM card, how they'll take the COVID test, and ideally be there for the birth of their baby girl in late August. So keep an eye on Emily's Insta. The details will be in the show notes. She's the egg and sperm race. And Emily said that her husband did say after a 5-year-long journey, it would be strange if things went smoothly. But wowzers, I mean, the resilience that we show on our route to parenthood is just amazing. So thank you, Emily, for sharing that. And we are going to be hearing next from Adrian Lower, who is actually the consultant that Emily saw. He's going to be talking more about Ashermans and about the work he does. Before that, though, I just want to make sure you know that both Kate and I are on a very specific mission to support you along the way, not just with the podcast, but in the work that we're doing. You'll know I've been talking about how I'm now qualified as a freedom fertility specialist, which is all about helping you with your emotional well-being. And I'm currently running a challenge in my closed Facebook group, Talk Fertility, called Save Your Sanity Whilst Trying to Conceive. And if you want to find out more about ways that we can work together, with details will be in the show notes. Kate works as a fertility nurse consultant, helping you understand much more about your cycle and understanding more about natural fertility methods, and she's a specialist in PCOS. So again, do get in touch with Kate. Both of us work in different ways, but together create this brilliant support package that I really want you to know is there, whatever stage you are at in your treatment. So if you do need more support, please do get in touch with us. We'd love to hear from you. Right, let's get on with the show and hear from our expert, Adrian Lower. So we're now going to welcome Dr. Adrian Lower to the podcast. Adrian is a consultant gynecologist and independent fertility consultant because we want to talk more about Ashermans. So Adrian, welcome to the podcast.
Thank you. Nice to be here.
Well, first of all, can we talk about what is Ashermans, to just explain it as clearly and easily as possible?
Okay. Ashland Syndrome is a condition in which the front wall of the uterus sticks to the back wall of the uterus. So it's caused by fibrous adhesions or scarring inside the uterus, and it normally results from surgical treatment of a miscarriage or a retained placenta or termination of pregnancy when the endometrium, the tissue which lines the uterus, is scraped away, maybe a little too vigorously or even with normal force. If there's infection there, that can destroy the endometrium. And then if you don't have endometrium between the walls of the uterus, scar tissue falls and it can obliterate the cavity.
You've just made, Natty and I watching each other on video, and you've just made us both squirm when you were explaining that.
There's no nice way to really describe it, though, is there?
No. But that's a very good explanation, though. That really does cover it well. I'm intrigued, though, what with regards to how many women may be diagnosed with Ashermans, and also, probably even more importantly, how many may go undiagnosed.
That's a very good question. Asherman syndrome seems to be largely unrecognized by many of my colleagues. The exact incidence of Asherman syndrome is unknown. Some people think it's as high as 5% of people who have surgical procedures on their uterus will have adhesions afterwards. I think it may even be more than that. The average gynecologist will see 1 or 2 cases a year, and a lot of people question whether it really exists or not. I see 4 or 5 people a week with Asherman syndrome, and I'm very clear that it does exist, but you have to look for it. You can't always tell from an ultrasound scan unless you're looking specifically for 1 or 2 very subtle and telltale signs. And the only real way to diagnose is by doing either a saline infusion scan, where you put saline in the womb to dilate it up a little bit, and you can then see the scarring and the tissue inside the uterus, or by a hysteroscopy, where you actually put a little telescope inside the uterus to have a look. But very often, putting the telescope in itself, if you dilate the cervical canal, the opening to the womb beforehand, you can break down the very adhesions that you're looking for and not even realize that they were there in the first place. So it's under recognized, but does cause problems. And then the other thing to say is that many women wouldn't even know about it. They'd find perhaps that their periods became a bit lighter after they've had a pregnancy, or a termination, and if they're not actively trying to conceive, they may think, "Oh God, that's nice. My periods aren't as heavy as they used to be," and they may even think it's a benefit, which perhaps it is if they're not actively trying to conceive. But for those women who are wanting to get pregnant, if part of the cavity is obliterated, it can have a really profound effect on their fertility, and often it is quite easily treated.
Well, I do want us to talk about how it's treated in a minute, but just in terms of that awareness piece and other signs, you mentioned the change in period. In the conversation that we had with Emily and Katy talking about Emily's experience, she talked about the blood in her period changing quite significantly. So do we think that we need much more awareness about those changes post a procedure being more linked to a possible sign of Asherman syndrome?
I think that if periods do change, then that's the first sign. And it's very important to listen to one's patients, because they will tell you what the issue is. And if the periods have changed, then you really have to investigate. You have to look and see whether there's a physical cause, whether there's some sign of Asherman's there. And the periods can vanish completely and be completely absent afterwards in some cases.
And I guess that can really lead then to it being misdiagnosed. So it could be that a woman might receive a diagnosis of PCOS if her periods are absent, although she should be tested properly.
Yeah.
But if a GP might just say, "Oh well, it could be PCOS." With that in mind, and when you mentioned about it being under-recognised, and you talked about how you can identify it through the saline scan or a hysteroscopy. Could it still be then not recognised unless you know what you're looking for and you're an expert like yourself?
Part of the problem is that if it's easy, it's very easy. But sometimes the reason that there is scarring there is because the uterus is a slightly abnormal shape or an abnormal curvature to it. And what might have happened is during the DNC or the scrape, whatever's been done to cause the Asherman syndrome, there might be a bit of a false passage created. So the probe or the dilator can slide underneath the endometrium and even into the muscle of the uterus rather than into the cavity itself. And the trouble is, when you go back and you try to explore that, unless you're specifically looking for it and doing it under direct vision or with X-ray control to make sure that your instrument is where you think it is, then you can make that false passage larger. And you think, oh, there's lots of adhesions here, and people who haven't got experience will sort of cut away trying to increase the size of that false passage, thinking that they're in an obliterated cavity, and in fact all they're doing is creating a false cavity and creating more difficulty and more damage, which is what the major concern of many of the women who post on the Ashermans website are concerned about, that people who don't necessarily have the experience try to perform the surgery and can make the situation worse than it was when they started, if that's possible.
I mean, hearing that, it's quite concerning in that when faced with these procedures, and it's not something that I've been through personally, but in the conversations that I've had with women, they just want the procedure over, and they're then in that vulnerable position of trusting that it's going to be the right thing. And I wondered what you thought about informed consent, of the risks of the procedure being highlighted more.
Yeah, that's a concern that many people raise, that they weren't warned of the risk of adhesions and scarring in the uterus after a DNC or surgical management of a miscarriage or termination of pregnancy. And there's no doubt that it should be included in the list, and people should be made aware of it, because then if their periods don't resume after the procedure, then they can investigate it and find out why it's not right.
And it's fair to say that it happens to some people. Some people get Asherman syndrome and others don't. Is that right?
Yes, I mean, some people go through a really massive, difficult procedure, placenta completely stuck and doesn't come away, and then their periods will return completely to normal and no sign of any adhesions afterwards. It's very difficult to predict who's going to get this.
What would you say to anyone who has had a trauma or a procedure, and there was the risk that they may have or may develop Ashermans? Would you tell them to be looking out for symptoms? Would you suggest that that's what we should be saying?
Yeah, I think they just need to keep an eye on their periods. I mean, it's not uncommon for the periods to be a bit lighter for a month or two after the procedure, and sometimes you may miss one completely, and there may be some scarring which just prevents the uterus from emptying the first period which comes along. But very often the second period, any minor adhesions may be broken down. So I think it's wrong to go in too soon, but I think that one has to be aware that it's a possibility, and people should seek investigations and seek professional help. The trouble is, most consultants don't see enough of this to recognize that it's a problem, and so there's an education process required amongst my colleagues as much as amongst patients to look out for this.
We're so used to now diagnosing PCOS, we're diagnosing more of that, and endometriosis, but I rarely see things like adenomyosis and Ashermans diagnosed comparatively. So you're right, that education piece definitely needs to be there.
So I think that if people are concerned that they might have Asherman syndrome, the simplest and probably least expensive investigation is something called a saline infusion sonogram. This is a standard transvaginal ultrasound scan where the anatomy is checked, but you also put a tiny little catheter into the uterus, which will allow you to instill some saline. So you expand the cavity with saline, and where the saline is, you'll see a black area inside the uterus, which is the water, the saline. And if there are some adhesions present, you'll see dense white areas on the scan, which are shining brightly. And it's a very easy way of diagnosing it. I think it should be mandatory for everybody going into IVF cycles to have at least a saline infusion sonogram, if not a hysteroscopy. But the hysteroscopy obviously is much more expensive and more difficult to access.
And can you see the patient power taking effect? I mean, we're seeing all sorts of shifts in conversations that are happening in between clinics and patients as a result of patients becoming better informed. Do you think that the clinics will take this on board and listen more if more women are going and asking for this?
I think it is expanding. I think that more people are having further investigations. The problem is, particularly in the private sector, if you put too many investigations in at the front end, you increase the barrier to accessing treatment. And I think you've got to be careful that you don't outprice the procedure. But when you look at the cost of a cycle of IVF, £5,000 or £6,000, the cost of a saline sonogram is about £500. It's probably worthwhile spending that to avoid wasting an embryo further down the line.
Yeah, 100%. So once a woman has had a definitive diagnosis of Ashermans, what's the treatments with regards to fertility, and then obviously for women who aren't trying to conceive?
Hysteroscopy surgery is really the only answer, and it should be done by hysteroscopy, ideally with a very small telescope, only 2 millimeters in diameter, with an operating channel so that you could put some very small scissors about a millimeter in diameter down the operating channel, and then those scissors will divide the adhesions which are present. That's all that you need to do, is to divide the adhesions, but it's getting the scissors into the right place, which is the important thing. And I tend to do these procedures with the hysteroscopy, so I can see on the screen exactly what's happening. And I do it under ultrasound control. So the patient has a full bladder, and we have a colleague shining the ultrasound scan over their abdomen through the bladder so we can see the uterus. And I can see that the hysteroscope is going directly into the cavity of the uterus and not creating or exploring this false passage, which I mentioned. And then we also do the procedure under X-ray control. So I have an X-ray beam in the theatre, and once we open the cavity, we then perform a hysterosalpingogram so we can confirm that it's open. We can also check the fallopian tubes at the same time, and it helps just to get a plain view of the uterus as well as what one's seeing through the scope. So there's three modalities, and that's easy for me to organise because I've got 2 or 3 of these cases on every operating list that I do. But for the surgeons which I mentioned who might only see 1 or 2 cases per year, it's very difficult to marshal that sort of equipment in place for a case which they're doing rather infrequently.
So for a woman who's not trying to conceive, would you look at a hormonal coil, for example, or what other treatments?
Definitely not a hormonal coil. I wouldn't. The trouble with the hormonal coil is that it secretes progesterone, and that thins the endometrium. So that is going to make the situation worse rather than better. It will stop their periods, but I think that if somebody is not trying to conceive and whose family is complete, then it probably doesn't really need treatment unless they're getting cyclical pain. The other thing which can happen with Asherman syndrome is if the outflow of the uterus is obstructed, then as the endometrium, the lining of the womb, is shed each month, it creates fluid inside the uterus that the uterus then cramps and goes into spasm in trying to expel that, and that causes cyclical pain, so monthly pain at the time that a woman would have her period. She get the pain but no blood loss, and so obviously that requires treatment. But If the periods are just lighter than they used to be, and she's certain that she doesn't want to have any more children, then I probably wouldn't treat it, because it doesn't go on to cause further problems, and it's not going to develop into something nasty, cancer or anything like that. It's just that part of the uterus is blocked so the periods are lighter.
So, Adrian, in terms of it being treated, have we got figures on how then successful it is, how much success there is for women to go on and get pregnant after having Ashermans, having it treated?
Not really. I can only go on anecdotal evidence, and I've seen, I don't know, 500 people over the last few years, and there's only a handful of those people for whom we've not been able to achieve a pregnancy. The good thing about Asherman syndrome, most of the people who come along are pregnant and may have had a number of pregnancies and miscarriages, but they are fertile, and they do conceive quite easily. And so if you can restore the cavity, the prognosis is very good. The problem arises when there's been really, really severe adhesions, or part of the endometrium has been removed, if you like, when a fibroid's been taken out of the uterus, and we can't restore the cavity. And for those people, then I would normally recommend surrogacy. So we take the uterus out of the equation, the ovaries are still working, they're still producing eggs usually, because most of them are young. And so then I recommend IVF surrogacy. But there's only been a handful of people, maybe 20 in the last, out of that 500, who've not been able to go on and conceive, that I know have come back and sought surrogacy.
Yeah, that's exactly what Emily, who we spoke to before you, that's the journey that she's now on.
So would you therefore say that if there's this lack of awareness among medical professionals about Ashermans, yet we know that if women are treated, or anecdotally we know that if women are treated, then the likelihood of them going on to conceive is really high, does that not kind of make you think that actually research in that area would be a really good thing to then be able to show the evidence and raise awareness?
I'm not sure necessarily it's research. It's very difficult to do surgical research, because to randomize patients, you have to get people to join into a study. Some you'd give treatment to, some you wouldn't give treatment to. Then you'd have to wait 6 months or maybe a year, and very few people would want to enroll in a study which they would know wasn't going to give them any treatment for a year, whereas the other ones would get treatment straight away. So I think that research and prospective studies are extremely difficult to justify and to organize. Everybody's going to want to have treatment, particularly as there's very little downside to the treatment, providing it's done properly. I think the answer is to establish regional centres. Difficult for me because I don't work in the NHS now, but I think that if we could establish regional centres where people would treat Asherman syndrome much more frequently, develop an expertise at managing this, and so that when they're doing the operating list and the procedures to treat it, they've got all the facilities available, the ultrasound scans, the X-ray tubes, so that they can do the hysteroscopingogram at the same time, and the outcomes would be much better, and the risk of causing further damage through getting in the wrong place would be reduced, and that would be the best way forward, I think.
So with that comes there being more awareness of people maybe putting themselves forward or presenting with the symptoms of Asherman's.
The trouble is, it's so badly managed that most people who have it will seek treatment outside of the NHS, and then there's only a very small handful of people who, like myself, who see these patients who have a reputation on the patient support websites and so on, and so the NHS doesn't get better because they don't see the number of cases.
I was just going to say, in terms of support, then we know of the Asherman Society. We know that there is an Asherman's Facebook group, which we'll put details of in the show notes. I just wondered if you knew of other areas of support.
Ashermans.org website is the only one that I know. The Mumsnet, I think, puts a bit on as well. But
I did a little bit of research before we spoke to you and just Googled Ashermans and support and see what came up. And there wasn't a huge amount there. Not, had I put in PCOS or endometriosis, I would be seeing a lot more.
Yeah.
Well, that's why we're making this podcast, to start the conversation and hopefully push it forward, and signpost people. And obviously we'll put your details, Adrian, as well, for people to get in touch with you. Thank you. I mean, that was fascinating for me to understand more about it. It's something that I've been aware of and we've been wanting to talk about in the podcast, but to really get to grips. And also, as we heard previously, Emilie's experience and Katy talking about it. Adrian, thank you so much for your time. Really, really interesting talking to you.
It's a pleasure. It's nice to speak to you both.
So thank you, Adrian. Thank you, Katy and Emily. All the details of our guest today will be in the show notes. Make sure you check them out however you're listening. If you haven't already subscribed, do so in your favourite podcast app. And you can rate and review us in iTunes and Stitcher. And Podchaser is another place as well, because it's always lovely to know what you think. Thank you for your support. We've got 1 week left of the Fertility Podcast of this season, and then we're having a little bit of a break. But until the next time,